Thank you for that great talk. I think we'll see if Miguel's ready with his live case. Miguel, can you hear us?
We're here.
Oh, wonderful. Yeah, well, we're waiting to hear what exciting case you have for us.
Loud and clear, loud and clear. Was that Darren speaking?
Yes, sir. How are you, Miguel?
Good, good, man. And you know what? It couldn't have been better because you essentially talked about everything we're planning on doing. So I want to say thank you to PK and the New York Endovascular Scientific Committee for inviting us. It's been a while. We've been working here behind the scenes, and I'm not talking about just today, but for the last couple of years in building what we're very proud of. We're transmitting today from Hope Vascular and Podiatry, which has been a project that's taken some time, but we're here. It's a limb preservation center of excellence, in my opinion. We have a one-stop shop that includes both vascular surgery, podiatry, wound care, hyperbarics, vascular diagnostics, and interventions. On top of that, we have also an integrated educational corner here with a classroom attached to the cath, as you can see here behind me. It's an 8-foot viewing window. So this is really our first official transmission. So we want to say thank you for y'all to allowing us and giving us that opportunity. Real quick, I'll talk about the people I have next to me. Andrew is always a phenomenal right-hand side. AJ, Daniela, and obviously the good boys from BAS who are always phenomenal at what they do. So let's jump into that presentation. That first slide is going to be one of our co-ed pride and joys. As you all know, we work very closely with Jill Somerset, and she has been doing tremendous work in teaching our team of vascular technologists and really clearly developing a map for us to know. I would even advocate to say that I trust this more than a CT scan because I have a lot of information. I'll walk you briefly over the left-hand side. This is a 76-year-old gentleman who has a TMA that we have been following for a while. Most of our patients have been patients of ours for a good 5 years or more. And although he is currently in remission, he started having a lot of left lower extremity distal pain, specifically nighttime, into the TMA distal segment. If you focus on the left-hand side, you start seeing the basics, right? Elevation of velocities in red. And then you have some color-coded in grays that show that you have severe calcification of the SFA popliteal. You have also less gray in the middle, talking about the type of plaque that we may encounter ahead of time. That helps us also potentially open some of the devices that we may use. And then as you go down, we see that there's an AT occlusion and that there's a Camerata 2B pedal loop, probably all feeding off of this posterior tibial. And more importantly than none, at the very end, you have a pedal acceleration class 4. That means that this is a very monophasic waveform, a tardus pardus that has over 400 milliseconds in this particular case. So from the initiation of systole to the termination of systole, we measure the milliseconds, and that progression of milliseconds talks to us about how bad the patient is. So the idea with pedal acceleration time is understanding that within the fact that all of them are probably going to be monophasic, because they're all diseased, they're all multiphasic, they're all multi-level, not multiphasic. It's who is, as you know, out of the monophasics, what's a good monophasic and what's a bad monophasic? And if you have a nice short pulsatile monophasic waveform, it's shown in our scientific revision that those patients actually do well. And so it helps us tailor care to those that really need it. So I'll jump into the presentation of that we've done here. I've got some angios to show you. As expected, that common femoral had that little stenosis that was already found on the duplex. The SFA is very, very diseased all the way down. You see the occlusion of the SFA here in the mid portion, and then it seems like that's a long occlusion down to the pop. And then, as you can see, the outflow is hard to see. Of course, there's a little bit of movement, but it seems like there's that PT and perineal mentioned in the duplex. And then even more so, distally, you see that TMA with moderate calcification. We calculated a max score of 3 in this particular patient. So we came from up and over. I'll just walk you real quick through where I'm at, and then I can open it up for a discussion here. Let me see, doesn't want to go forward. Let me show you what we did next. So this is also very telling. I think this is an interesting finding. This is just a simple wire. The sheath is clearly luminal, but immediately that sheath is going into the subintimal space. I mean, this is just with very low pressure. So, I had to do a little roadmap to try to get that through. Took my time to torque through it. But then as I'm getting into the SFA, same thing, right? You start seeing, normally these wires will either knuckle and just flow through into the lumen. But when you start seeing this with just the very basic soft wiring, you know that this is a very brittle artery, that you're going to be out in the subadventitial space. You're going to be in and out. You're going to have to be very, very judicious. To Dr. Schneider's point, you have to realize that soft wires that'll keep you luminal are probably the way to go. And we tried that even into the proximal CTO, and really we were going in all these directions. And just, I could probably push more of this, but just seeing the wire, I'm feeling that I have to probably come from below. And based on what I have, I mean, I could do a plethora of access, right? I could probably use the occluded short stump of the AT. I could probably go down to the distal posterior tibial. But because of that calcification and the small athletic nature of that artery, I've considered just doing a distal popliteal access in a retrograde fashion, but from the anterior lateral approach, which is not necessarily flipping the patient and making a big production out of it, but actually opening the tibia and the perineum so that we can get the access from the lateral anterior side of the artery of the leg. And with that, I want to open it up for some questions or discussions. And as I'm going to start kind of prepping the access side, because I like to show you, I cut a window, I put a little bump on the lateral side of the foot so that I can create some internal rotation, and that opens the window for that access more appropriately.
Oh, thanks for that case, Miguel. Really, really interesting. I just want to introduce you to the panelists here. We have Dr. Caraccio, Dr. Cruzan, Dr. DeRobertis. We have Dr. Desai, Dr. Schneider, Dr. Szczesinski, and Dr. Zeller. I want to just start with the panelists. How would they approach? Would they do the femoropopliteal segment? Would they intervene on both the fem and the infrapop? Would you just go directly with the dual axis approach? I'll start with that.
Well, I mean, I think the way Miguel's doing it's great. The only thing before I bailed on coming from above is I might just have tried with a support catheter just to see if I could get across with a wire and support catheter before I abandoned it.
Desai?
Yeah, I'd probably try again from the top, and but the more you try from the top, it's likely that you're going to dissect further. So I think probably come down below, come down little.
As my colleagues here, I would give it wouldn't make it too excessive, but try from above. But yeah, why? Just curious, why the popliteal and not the stump of AT or something else that may be easier to get to?
Miguel?
Yes, the other microphones are a little low, and I have a lot of delay, so like I'm listening to myself speak a lot, so I apologize for that. But if there was a succinct question, please repeat it.
The question was, why ultimately did you choose popliteal rather than, let's say, a stump of AT or something else from below? Did they go?
Small calcified vessels. I had already looked at it on the ultrasound, lots of shadowing. And this is a particular technique that is relatively straightforward. Gets you into a bigger lumen. If I need to, I could even place a sheath if I think so. Although I do this in a sheathless fashion, I don't necessarily put a sheath. But those are the reasons. Small vessel, highly calcified, lots of echogenic shadow on ultrasound.
And just to follow up to that, and is it because you're planning on just doing the SFA, or you're going to continue in another step?
Potentially. I think this is multi-level. So the way I would go about it, this is actually a really good question, is I'm going to focus on this SFA popliteal occlusion. I'm going to open it, and then I'm probably going to do pedal acceleration times on the table. If I see that we progressed at least 2 classes, then usually I'll just leave it alone. I don't think doing a 30 centimeter CTO of the AT makes much sense in this particular case. So I'll take some light. So anyway, as you can see there, you know, you rotate the foot in with just a little, I put a little bump on the lateral side of the foot. And then with that and a little bit of LAO, this is the left leg, so a little bit of ipsilateral obliquity, then you kind of get yourself into a sweet spot. You can see that the artery there is relatively clean, but also you can see it if you look at, let me give you a single shot here. You could probably see the calcium. So you have some degree of roadmap there.
You do this completely under fluoroscopy?
Yes, sir. Yes, sir. Yeah, this is a little bit of a tough spot for ultrasound just because there's so much soft tissue that you have to go through. Whereas if you do it fluoroscopically here, I'll just show you the 2 basic steps, which is just go AP, get flow, and then potentially change, make sure that it's looking in the right place. And with a different projection, you can actually determine where you're at in the lumen, I mean.
Rest of the panelists, what would you guys have done? What do you guys have done?
Yeah, I actually think this is a great approach, Miguel. So when you have a really difficult above knee pop distal SFA occlusion, a lot of people tend to go very distal at the ankle or the foot because they're used to that, but you don't really have all the control and pushability and things that you may need. And this gets you right on top of where you need to go. So I use this technique specifically for situations like this. And we'll see later, I think it'll be very interesting. The biggest problem with this technique, it works great. You can access through the interosseous membrane. You can get to the vessel, either if there's calcium or angiographically like Miguel's doing with perfect technique. But it's really the exit strategy because this is not a place that you can easily compress. So it'll be interesting to see what the strategy is for that. I've got my own, but I'm interested to see how Miguel does.
Yeah, and like everything else with access, there's some body habitus limitations. I mean, a really big leg, lots of soft tissue makes it a lot more difficult.
But I do think that this is an underutilized technique. I don't actually hear about people talking about this as much, but it can be very valuable if you're trying to cross a popliteal occlusion.
Then the other detail here, Darren, is I know you're a fan because we've both been on courses where we try to teach this. The other thing is that don't use any wire other than a wire that's hydrophilic with good support. So in this case, a V18, and I like to use a very short V18. Can I have a little more light of me? I'll use a very short V18, and then what I do is I use a microcatheter, a short microcatheter, in which case I've selected an angled navicross. So I'll just show you guys here. It seems like, I mean, it went soft, but obviously, God knows, you never know. And if it's a live case, something always happens. But we'll take a look-see here shortly. I'm going to get enough purchase to where I'm happy with it. I like that. I think that's already kind of going into the CTO. And I'm going to ask Andrew here to take that needle back and give me that navicross. The idea of this navicross is it's braided, so it's got a really good pushability. It's angled so I can redirect. And I'm not putting a big sheath. So to your point, hemostasis, which can be tricky, is easier than usual with a smaller stick. The other thing that I like about this is that we don't, hold that wire, Andy, please, is that we don't, let me get my hands out of here, is that we don't stick the vein. I can't tell you the amount of times that I've been referred patients for large fistulas at the popliteal level after somebody's done an access through the back. And so by hitting it from the front, you're really avoiding yourself. Can I get a new one? You're really avoiding yourself that whole mess. So anyway, let me take a quick picture here. If we're if we seem to be in the right spot, then I'll start just working. Yeah. And you guys can go on to another talk if you want, but if you guys want to stick around, I'm super happy to have you here too.
We go on to another talk, or I think Dr. DeRoot.
Just Miguel, this is Brian. I have nice to see you, brother. Hey, I have another question about this access issue. Why choose that versus a medial approach to that same spot? I don't actually do the medial approach. I do what you do, but just can you talk through why you choose that versus a medial approach, as a lot of people will do?
So on the medial approach, I think also you have a lot of venous structures and a lot of more soft tissue. You can definitely, your ultrasonographic window is going to be better, to be very, very honest. And so I think I would advocate to see if the window is good and you have an access site there, that helps. I don't know if, and this is just hypothetical because I don't necessarily have done that a lot, but I don't know if the hemostasis part on that medial aspect, is there more of a space, more dead space, right? I mean, when you open the popliteal from the medial aspect for an open bypass, it's such an easy place to dissect and to create a large hole. Whereas from that anterior approach, I think that there's a lot more tissue apposition. But
I
again,
generally
may
do
just be
that
talking
medial
crap here,
approach
'cause
for
I don't know if there's a true.
For the above knee pop,
reason
I
for
think it
not
works
doing
great
that.
for that. If you puncture about the level of the upper patella, you get into the above knee pop if you're dealing with difficult SFA work. But I like this approach if you want to access the below knee pop, because I think it's a lot harder and deeper from a medial approach. And this allows you to as Miguel's shown, keep the patient supine. You don't really have to frog leg or do any weird gymnastics to get the access. And then it's easy to work just with the whole leg supine with this access. So this is the way I go below knee, but I think your comment about above knee pop from a medial approach is definitely the way to go for that.
Yeah, I do the same. Above knee pop, I always access medially, but for the below knee, I do it this way, and for the TPT, I do it this way. But because you cannot compress through this approach, I never use more than a wire here and the micropuncture.
100% agree. I don't put sheaths in through this approach.
Have there been any complications, just AV fistulas or nerve injuries or the risk of a compartment syndrome we should worry about? Because I don't think this is something which most people do.
Well, I think you have to worry about compartment syndrome anytime you're puncturing in the deep posterior space or anything like that in the leg where it's difficult to compress. So you have to be totally cognizant of that and be sure that you don't have extravasation and that you get hemostasis. I don't see AV fistulas with this approach, and if you use the medial approach above the knee, I don't usually see AV fistulas with that either. So I think it's just learning the technique and applying it properly.
That's actually a really good point. I'm sorry to interrupt. That's actually a super good point that whenever you start doing any of this, you need to make sure that you take the time to train your staff that's going to recover the patient. So our cases, they get groin checks, they get puncture checks, they get motor checks, they get compartment checks, they get sensory checks throughout the next few hours after it. And we also leave the room with an absolutely clean angiogram. So I'm not going to, if there's any extravasation, I'm not going to leave the room. So that's the other. So 2 rules: have really well-trained staff to pick up on any odd potential issue, and 2 is just leave the room with an absolutely clean X-ray and a duplex that confirms that.
So I think, Miguel, while you're working, we'll go for another talk. We would like to invite. Thank you, Dr. Zeller, for that very informative talk. I think we'll go back to Houston. I think they've just crossed. Miguel, can you hear us? Miguel, can you hear us?
Like we really did. Yeah, I can hear you. Can you hear me?
Yeah, we can hear you. Sorry.
We good?
Good.
Okay.
So just explain.
Yeah,
I think you just
so
crossed.
What we did here, so what we did here was I was having a lot of trouble getting into and re-entering this. I was using a V18 control wire. And because of the nature of the V18 control wire and its hydrophilicity, it was essentially continuing, not in the lumen, but actually dissecting all the way up into the artery. And so what I did is I did wire escalation, and we opened an 014 an Astato 20, was it? An Astato 20, which is a CTO wire, created a tiny little angle on it, and used that to just redirect ourselves into the lumen. Once we got into the lumen, this is a shot from the microcatheter, confirming that we're in the lumen. And then I should have recorded, but what we do is normally we then change to a very small hydrophilic wire, a Command ES. And what I did with the Command ES is I navigated it from the bottom up into an 035 Bernstein catheter that I have in the SFA. And so then what I do is I connect those. You see here is that connection. So the 018 microcatheter feeds into the 035 microcatheter. Well, what is that? Why would you even waste your time doing that? Well, because now I turn the wire around and I feed the back of my working wire. I'm already thinking that this is potentially going to be a Rotarex case because of the soft plaque from the initial duplex. But this is the time where you could maybe feed a Rotarex wire. You can feed a Viper wire. In my case, I fed a Command ES wire backwards, which I've had a lot of success in using as a working wire, even over with pairing it with a Rotarex device, which of course is out of the IFU of the device, but it's worked really well for us. So,
Miguel, actually, before you go ahead, before you go ahead, I want to ask you a question on the crossing technique and also to the panelists. I saw that you're predominantly trying to cross retrograde, and there was a collateral, and there seemed to be a favorable proximal cap. My concern is, if it doesn't cross right away, then we are concerned we're subintimal and we may shut the collateral. Were you ever thinking of placing an 035 catheter in the proximal cap and then trying to cross to preserve the collateral? And just wondering what your thoughts and what the panelists would do.
That's a great point. I had already actually asked for an 035 catheter that I could put in so that I would create a dissection in from the top to preserving the collateral, and then potentially doing this rendezvous in the middle of the CT out, preserving the best of both worlds, if you may, right? Yeah. But right when I asked for it, the wire just fell back in. And it seems like, I don't know, I feel good about it. Let me show you. It looks like the catheter is right in the cap. And I guess we can see by IVUS if we feel super strongly. We can just rewire this. It'll take a minute, but I think it's going to be okay there. It looks like it's re-entered proximal to the collateral from the bottom up, or distal.
Yeah.
Well, one way.
But thoughts from the panel?
Yeah, one way you could have easily guaranteed that you re-enter into the right lumen would have been to pre-dilate a couple of centimeters from Antegrade into the occlusion, and then can navigate the guide wire back into this even subintimal lumen from above, and so you would have been sure that you crossed back into the lumen distal to the offtake of the collateral vessel.
But I agree that the cart technique, that's a way to do that, to get in from above balloon and then get your wire into that fractured,
what happened?
Across the fractured tissue that you fractured with the balloon. I thought your technique was perfect. I think the other thing is that I think sometimes it may be heresy that we think too much about trying to save that collateral. In that location, I don't think that collateral is as important in getting a good, excellent technical result, which is more important to me in opening up the femoral popliteal artery and doing something that I think is going to be durable. That whole segment's diseased. If you looked at that angiogram, that collateral had a tight stenosis at its origin. I don't think that's the most important vessel for him. So yes, I try to preserve it, but for me, it's not the end of the world.
And Miguel, you're saying that you were thinking of doing a Rotarex, I know even before the IVUS, is just based on the feel that the plaque felt pretty soft, even though I could see some medial calcification.
Go ahead and record, please, there. No, it was primarily based on the duplex. We try to do a lot of echogenic analysis when we're doing duplexes, and so I asked the techs to actually give me a heads up. Is this soft plaque? Is this very organized plaque? Are there a lot of calcified windows? We're also working on an ultrasound-based calcium score for determination of MAC scores. So, yeah, I was already somewhat biased by, can I have a pickup or something? Biased by the images of the duplex.
And so now you
You can stop the recording.
so now the plan is to IVUS and then probably go ahead with the Rotor-X?
I think so, yeah. So one thing that I'm looking at here, and that's why I'm just putting that little mark outside. Go live again, please, on the IVUS. Here, I'll show you. Okay, so this is the pop below the knee. This is the, oh, you have it on your screen. What am I doing? Sorry. Then you see right here, probably in the, as you go into the P2 segment, that's just a bunch of soft stuff. But I am luminal. And then here where I put my mark, I am under the impression, I'd like you guys' thought, is that maybe I'm outside for a little bit, right? Are you also under that impression that this may be
Subintimal?
I call it subadventitial, but subintimal?
It looks subintimal there for sure.
What do you guys think?
But just a short
Yeah.
segment. And it's really good when you're doing a marking this on your angio because, again, you can direct your therapy around this if you want to leave it or, you know, more dire circumstances recross. But it seems like you're back.
That's it. That's it.
Yeah.
You know, I think with the Rotor-X, you have to be a little bit more respectful. Well, any atherectomy device. And so I like to know, okay, from here to here, I may be in a subintimal space, and so I'm going to be a little bit more cautious driving the device through that. But there is certainly value sometimes on the proximal and distal cap of your CTO. Like you see, that's luminal clearly again. So I think that from here, I'll take the scissors now. From here to here, there's potentially a subintimal crossing. And so maybe I'm not going to be as aggressive if I have any jerk, any clutching of the system. I'm not going to push it to do what I don't think it should do. But then right at that edge and going backwards, look at there's still a lot of stuff in that lumen. And I do think that a lot of these CTOs are a combination of plaque and then the soft thrombus that's on the top and the bottom. And that's what sometimes kicks your butt, right? I mean, you end up this beautiful procedure, and then there's a little booger all the way down because you missed the fact that there was a big 2-centimeter clot burden at the proximal edge of that.
I was sorry to interrupt, but I was just going to say that. I would not, but I'm curious, playing devil's advocate, given what you're seeing there, would you abandon the wire from below to put a filter in?
I personally wouldn't. No, I feel very strongly that with the Rotor-X, the efficiency of it can allow me to clear as much as I can. And I'll be very cognizant about how the device is functioning through that area. So if you guys want, I don't know what the time's looking like, but I can start doing a little bit of rotor here in the back end, and you can check on me in a bit.
Thank you. Thank you for that great talk. I think we can go back to Houston. Miguel?
Hey guys, what's up?
So I saw
How's it
you.
going? Oh God, can y'all thing that cosa? That cable is so not pura vida. All right, so here's what we did. Let me go back and update y'all here. So we did what we talked about. We went in with the Rotor-X very, very slowly. Used a lot of back and forth when dealing with the areas that were clearly luminal, so you could be a little bit more aggressive. And then I was very cautious going into that adventitial, subintimal space. But this catheter is very hypersensitive, so as it latches onto anything it shouldn't, it immediately clutches the system. So if you get a clutch, you can just push it a little bit and then go on. But you know, surprisingly enough, it didn't clutch at all through that. It went all the way down, so I was able to get down into that mid portion of the popliteal. And then I want to say this is the image post. This was open. We didn't have any problem there, but that collateral, thankfully, is still there. And the artery actually looks, this is just with a few passes, it looks pretty darn good to to be honest. So I decided I want to take a peek with the IVUS again, see where we're at. So let's go down here.
And the IVUS is to see
One
any
important-
residual thrombus or to size the vessel, to look for any...
Size, yeah, I want a size vessel, and I want to just make sure that I don't need to, that there's nothing really that I'm scared of that I'm missing on the angio. You know, I talked about the little booger that just catches you towards the end. Go ahead and store that, please, AJ. Oh, Daniela, please, can you just store? Yeah, go ahead. Press record. Thank you.
So I guess the next thing would
So
be...
there's just a pullback.
take a look
You
at
can
the
see
side.
that area of that popliteal that got treated, and then this is into the CTO that we had. Noteworthy, you have some pulsatility already in the artery there. And I'm going to just do a little bit of a quick pull, but you see that essentially kind of opened up that subintimal space well. And then going here, this was all clot in the lumen or homogeneous material. You see how this has been removed. I mean, obviously not totally. This is debulking, thrombectomizing, and we still need to consider doing something. There's a very diseased artery from the bottom to the top, so I'm thinking maybe a DCB, like a 6, I'll measure it right now, but maybe like a 6/300, and just tack up the whole thing. And then decide based on that if we really, you can stop recording, if we really need to put a scaffold of some sort or not. Would like y'all's opinion if, with what we have right now, which seems to be rather, I would say, good angiographic results. Here, I'll show you that, and I'll show you maybe this one. Are you guys committed to a scaffold just because we're subintimal at this point, or do you guys think that maybe if the DCB continues to look like, and maybe we do ultrasound on the table, and we have a nice triphasic waveform, I should probably just leave it? Thoughts?
I think George's got something to say.
Yeah, I mean, based on that image, it does look pretty good. So I'm
Measure me in
definitely
diameter.
not. I'm definitely not as committed as I may have been to a scaffold. So I think you can size something appropriately DCB wise and then see how it looks. I think that's a very good strategy.
Yeah, it's pretty interesting to see how that subminimal space opened up. I wouldn't have expected that. So I think that to your point, George, like that gives you some reassurance. And I bet you after angioplasty also it's going to look even better. So I think that was nice, Miguel, to
Right.
really feel comfortable
I'll go back.
a little bit hitting that. Yeah.
Right there.
So Dr. Shimsky, I have a question for you. You know, when you perform your debulking and you do an IVUS, is there any objective criteria? Yes, this amount of debulking
Dots,
is
come
good
on, dot,
enough
dot,
for
dot.
me to do a DCB, or I might need to do another
Oh,
round
that's
of
way outside, Gal.
debulking. Do you have any objective assessment, or is it just a visual?
Yeah, I mean, there's a lot of, I think we know that from even PK's data that more than 30% residual restenosis is the biggest predictor of DCB failure. So, I mean, I think when you're going through that, it's hard to
Let's go with
optimize to that point.
6/300, please.
But, I think that we're looking for those areas where you still, and we saw a little bit here, but we'll see what angioplasty does where we still
All right,
need
switch to the
to
angiogram,
do a
y'all.
little work. Things I'm thinking about in this specific case, again, is how deep are those dissections. In particular, there's some IVUS-guided dissection measurements you could do, including the depth of the dissection, the arc of the dissection, that can tell you about early patency failures. And so, I think it's really nice to spend the few minutes that Miguel did here to take one more IVUS run. And you can see at the same time as you get more efficient, you're looking at those parameters and sizing your therapies.
Yeah, and I think also, not that it was with this device, but we know from DA that if you IVUS and you see some deep adventitial cuts, then that may push you more to scaffolding because you know that that's going to lead to restenosis.
I think we'll go on to the next talk in the interest of time, so I would like to invite Dr. Caraccio. Thank you, Dr. Caraccio, for the case. Miguel, we're back to you. I see that you probably have done some DCBs.
I don't have anything really exciting to show you. We decided to go with a 6/300, and now we're doing a 6/220 for the top. This is where we're at. So I'm just going very, very slow I'm bringing this balloon up. So if you guys want to get another talk going, I should probably have an image to show here in a bit.
Yeah. So Miguel, actually, we're already 15 minutes behind the next session. So what we'll do is we'll wrap up here, and then we'll come back to you to see the finish. And I want to thank all the panelists, and it was a great, great, great session. Thank you. Appreciate it. Thank you.